Margaret Moige is a blood donation, works for Kenya Tissue and Peter Mbogwa. Peter Mbogwa is a senior lecturer at Kenya Medical Training College. He has specialized in blood transfusion sciences, and he'll be one of our panelists. We are also expecting Dr. Teresa Lotodo, a consultant hematologist and a lecturer at Moi Teaching and Referral Hospital. And also with us is Alfred Obengo. Alfred Obengo he has been working in the blood field and also a board member at Kenya Tissue and Transplant Authority. So with this one, I want to welcome Margaret Moige to do the presentation. Over to you, Margaret.
How are you, everyone? I hope you are getting me.
Yeah, we can get you.
My name is Margaret, as you said, Moige. I work in Kisii Blood Transfusion Center. Today we are here to talk about donor recruitments. Donor recruitments is a continuous process of data collection and analysis of adverse donor events and reaction in order to investigate their cause and outcome. Donor recruitments. Sorry. So we are going to talk about donor recruitment, blood donor collection, and donor care and counseling. So we have what we call, in donor recruitment, we have what we call donor haemovigilance. In donor haemovigilance, we normally ensure that we have a continuous process of data collection of the donor. Then, after that, we also take care of donor documentation, reporting, and the data should also be regularly analyzed in order to undertake possible preventive action. When we are doing donor recruitment, we have to improve donor safety through implementation of preventive action to fight the occurrence of adverse donor events and reaction. Tracing of donors and withdrawal of donation that may have or could contribute to serious adverse reaction is in the recipients. We also have to do improved patient safety through better donor selection, criteria, and process. We also have to do what we call epidemiology follow-up. That is, should give information about any adverse events in the recipient of transfusion, should give a feedback into the donor infusion system to improve donor selection. So we also have scope of donor haemovigilance. So donor recruitment and selection, there's this now in donor scope of haemovigilance, we have donor recruitment and selection, whereby we also do a phlebotomy for donor collection. We also have what we call donor care, pre and post-donor counseling, donor-related adverse reaction, blood donor notification. Before I go far, I want to talk about this scope of donor haemovigilance, about the donor recruitment. Donor recruitment normally starts straight away from when you get the clients for donation. We do it by going to different institutions whereby we can get the right donors to donate blood. For example, we normally recruit institutions like universities. We also recruit institutions like schools, churches. We also have recruitment of donors who are called walk-in. The walk-in donors, normally they are volunteers. They come in willingly and wanting to donate blood for any patients in the facilities without necessarily getting related. We also have autologous donors. Those are the type of recruitment donors we have. Autologous donors, they are the type of donors that donate their blood before they go for, maybe they are scheduled for a surgery. So they donate blood, the blood is kept, they come to use it later. Normally, the walk-in donors, they are those ones very willing, and they normally become regular when they have been recruited. Like for example, we have these walk-in donors. The men normally donate after 3 months, and ladies donate after 4 months. So they normally come and they take it as their own responsibility. Also, I said about the schools where we recruit donors. In the schools, we have students of secondary schools, not primary, secondary school students. They are the ones, because we have age limit in recruiting donors. We normally have 16 years and above donating blood. So that's why we don't go in primary school, because most of them are underage. We also, those who are 16 years and above are found in secondary. So we go to secondary schools, then we give them a health talk. Those who are willing, they can come in and donate blood. I also talked about universities. Universities, at least all of them have met the criteria of blood donation. We will see when we go to donor questionnaire, those ones who meet the criteria to be recruited in donation. I also want to say, in churches, we also go there. Firstly, we book for this session, then we go there. We also give a health talk. Those who have met the questionnaire requirements, then they're asked to donate blood. In that donor recruitment, we tend to maintain our regular donors by ensuring that we give them a call when they are due for donation. Also, in the recruitment session, we have what we call rare blood groups, whereby we have a record also to maintain these donors who are rare blood group, maybe O negative mostly. We call them, they normally come and donate. After we have done our recruitment, then we go to a session known as phlebotomy. Phlebotomy, we have what we call the collection now of the blood products. When we are doing the phlebotomy, we ensure that proper phlebotomy is done. The client has been recruited to donation, meaning the client has gotten the right requirement to donate. Now we are doing now the phlebotomy. That is now we are ensuring that we are collecting the product. We will ensure that proper cannulation is done by ensuring that we swab the collection sites. Then we have 3 sites to collect blood. That is sites of a vein. We collect blood from the vein. And the vein, we have the median vein. We have the cephalic vein. And we also have the median, I said the median, the cephalic. Kwamboka can help me there. Are we together? Are we together, brethren? Phlebotomy entails that you do a thorough procedure. This procedure entails that we should thoroughly observe aseptic technique when we are doing the phlebotomy procedure. Therefore, somebody who is responsible for phlebotomy should do what we call well gloving. If the site where you are going to collect blood is not clean, then you should clean with soap and water. Then do what we call swapping. You swap the site. When swapping, you swap inside out once. Then you insert the cannula. And then after inserting the cannula, you secure the cannula. Then you wait the blood to be collected in the blood bag. And then you collect the blood samples, ready to transport them to the laboratory for screening and testing. We go now to donor care and post-donor counseling. Mostly here, I'm going to deal first with the donor care. After this client has completed the phlebotomy, now the client is supposed to be taken care.
Margaret,
Yes.
before you proceed, you had asked for me to add something on the phlebotomy.
Yeah,
The sites, eh?
Yeah.
Yeah, I request that you move up your screen.
Yes.
There is a picture of the site of phlebotomy.
Yeah.
Just move up your screen. We see the slide where the sites, where the appropriate site where donation is done.
It is here.
And as he moves up the screen.
Yeah, it's already screen. The screen is already there.
Yeah, those are the sites where the best veins that when we are doing phlebotomy, you can collect a full pint of blood. That is the
So-
cephalic vein, the basilic vein,
And
the
the
medial cubital vein.
Yeah.
Yeah, you continue.
Thank you for that correction. I said now we are going to donor care. After we have collected after the client has finished with the phlebotomy, now we have to take care of this client before we say bye to the client because of some reaction which normally occurs after donation. In donor care, we ensure that the donor is stable before coming out of the donor couch, because normally some feel dizziness, some can even vomit if you remove them from the donor couch very fast. So we ensure that they rest on the couch for around 5 minutes. And then they move out, they sit on the chair. When they have sat on the chair, we normally give the donor refreshments. The donor refreshments, that is, we normally give soda, that is Fanta. For those ones who don't take soda, we give milk. We normally select to give soda Fanta because it gives energy and replaces the lost fluid, that is 500 ml, and that's the soda we normally give. We also give bread so that the client can gain energy and go home. Then, during the care, we talk with the clients about how important the donation is. That is now the donor counseling. And that is now post-donor counseling. We counsel the client, we tell the client the importance of donation, what is expected, maybe the reaction can occur at home. So we tell the client what is expected of him or her at home. Maybe she or he might feel some dizziness at home. So we tell the client that this is normal. We encourage the client at home to take a lot of water, to take a lot of green vegetables. And then we normally tell the client that it's very normal after 24 hours, her resumption of normal duties, even doing what she wants, can continue because blood donation does not have so much side effects. We also counsel the client and tell them when they are supposed to come back for another donation. We also give them a donor card post-donation. The blood bag, the blood donor card bearing the blood groups, name of the client, and the date of donation and the return date of donation. So the clients go home with adequate knowledge, knowing that he or she shares the responsibility of coming back to donate blood. We also teach them about the related adverse reactions. Maybe this donor might develop an hematoma. Then we tell them it's normal and it can also go away. We also tell them about blood donor notification and the linkage to care. We tell them that after maybe some 1 week, they can come. For example, ours is a satellite. We normally don't get the results immediately, but those ones working in the region, they can do the screening and give them even the results immediately. That is what we normally call donor notification. So for us in the satellites, we give our clients 1 week for us to get the results because we normally send our samples to the regional centers for screening. When they have come, we advise them post-donor counseling. We dare them to come after 1 week to collect the results. Now, after collecting results is when we will organize for the linkage and care in case the results were positive, and in case the results were negative. And then we advise the clients to continue. We call the client back to continue donating. Then after that, we have what we call, I've already talked donor recruitment and selection, which I've already talked that blood donor is a person who voluntarily gives blood or one of its own components. The ideal blood donor should be 16 years to 65, I've already talked. And they should also, sir?
I don't know if you can move your slides. Your slides are not moving. Just to put a slideshow and move it.
Okay. The male donor should be having an HP of 3 grams per deciliter, and a female donor should have 12 grams per deciliter. We should also have a donor who has general good health and has got any medication currently when we are recruiting the donor. The donor also should not be pregnant and with no chronic illness. Okay, donor recruitment and selection, they are the things that I summarized, but now we can go slide by slide. The donor should be in good health at the time of blood donation and free of infection transmittable by blood. Infection transmittable by blood. Normally, the ones we check are HIV, hepatitis B and C, and syphilis. So this donor should be free of these diseases. Donor recruitment and selection aims are to ensure that collection of blood is only from donors who are at very low risk of any blood-borne infections and who are unlikely to jeopardize their own health by donating blood. We not only recruit them because they have come, we normally also look at their health by testing all that is needed, like testing the HP, taking a good history, and knowing that this client really, if this client can donate, can as well remain to be healthy. A rigorous process to assess the sustainability of prospective donor is therefore essential to protect the safety and sufficiency of the blood supply, as well as to ensure the health of the recipients and donor, while ensuring the suitable donors are not deferred unnecessarily. Like, for example, sometimes you can get that some people don't have the machine to check HP. They normally do the checkup by using normally some people use manual checkup of HB by checking the conjunctiva, and they can easily defer the patient unnecessarily. Unlike the person who normally uses the Haemovigilance or the HP checkup machine to ensure that this client is really ready for blood donation or not. Key tool in donor selection is the donor questionnaire. This tool is used in assessing the donor health and for reducing the risk of transmitted infections. The key principles of blood donor selection are as follows. The health and safety of the donor as well as the recipient must be safeguarded. Only individuals with good health should be accepted as blood donors. A prospective donor's health status and medical history should be evaluated prior to each donation. The donor should be provided with pre- and post-donor counseling and the notification of the results of the TTI screening. The selection should be based on regularly reviewed criteria without discrimination. So in donor selection, we should also have effective client donor education, that is the health talk, as the first step in the process of donor selection. We should also have information to potential donors about the healthy conditions and risk behaviors that could make them unsuitable as blood donors, and the screening tests that are performed on donated blood enables prospective donors to assess their own suitability and provides an opportunity to self-defer. Like, for example, when we ask our clients, have you had a sexual relationship with a person whose sexual background you did not know? When the client answers this question as yes, and then we know this client has engaged in a sexual relationship without any protection, most likely any other person is supposed to be suspected of HIV and or any disease that is transmitted through sexual relationship. And then this client we normally defer them, or they can self-defer when they have put a yes in that question. The venue of blood donation selection should provide adequate privacy and confidentiality. Because even of the nature of the questions we ask these clients, and any question asked to a client or a patient is supposed to be kept very, very confidential. So that's why we also encourage that our venue should remain private and confidential. Sufficient, sustainable, and well-maintained equipment for donor health assessment should be made available. This includes the BP blood pressure machine, weighing scale, HP screening machine, essential consumables. These are the essentials, and I know everybody knows the weighing machine, the blood pressure machine, HP machine, we have the remote cube. Let's continue. We also have a tool known as a donor questionnaire. The donor questionnaire is the key tool in donor selection. It is used to assess the health of the donor. This is aimed to reduce the risk of TTIs and to safeguard donor against donor-related adverse reactions. Like, for example, when you ask a patient, do you have any reactions? Have you had any reaction with any drugs before? So if this patient, do you have an allergy? When you ask the client like that, then you are able to know that if this client has got a permanent allergy, this patient is not fit for donation. We also have standardized donor questionnaires, widely accepted as it ensures uniformity and consistency. This questionnaire is made using an SOP. They are standardized, as they say, and the standard is all over. This is the questionnaire they are using all over the country. Also, a donor demographic, medical, and social history is captured in this questionnaire. The questionnaire is given to donors at the time of registration of completion before the donor interview and assessment. A donor questionnaire facilitates decisions on the acceptance of deferral of a donor. Like, for example, you can get a donor and the donor insists that I want to donate. There is a case scenario where we have those donors with polycythemia. They normally insist that they want to donate blood, and normally these are not clients eligible for donation. This questionnaire gives them a chance to be explained that this HB is too high, you are not supposed to donate, and then they see the importance of deferral or even self-deferral. A standard questionnaire that elicits a prospective donor demographic, medical, and risk history should be used throughout the country, which I've already mentioned. Donor selection staff should be trained to recognize donors having difficulty in understanding any questions and to explain the questions and facilitate the process for donor to provide accurate response. Normally, we receive even clients who don't know how to write, they don't understand because normally the questionnaire is only in English. There are those who understand their mother tongue, there are those who don't even understand Kiswahili. So you help them if there is a translator, even those ones who are deaf. We are requesting in future in all places of donation centers, we should have the translators of the deaf, we should have those mother tongue translators so that the questionnaire can be filled appropriately. But for now, all the questionnaires are set in English, and there are those ones who don't understand in reading the English, so the trained personnel is put there to translate and ensure the questionnaire is well filled. All prospective blood donors should be assessed prior to blood collection for their suitability to donate blood prior to every occasion of donation. This is what I said, that we normally carry out the HP checkup. We normally strictly look at that questionnaire, the way it's answered, if the client has been operated previously and has not finished the required standard amount of time, that is maybe after surgery 1 year. We strictly look at that and we ensure that this client is really suitable for blood donation. Staff working in donor selection should understand the principles and the basis for donor selection criteria and have the technical and clinical skills required to perform the healthy and risk assessments. This one is clearly understood. The key skills, knowledge, and competences required for staff involved in donor selection include understanding the donor selection criteria, pre-donation information and counseling, interview and assessment based on the questionnaire, ability to explain the questions in the questionnaire to potential donors. Also, basic health checks. That is now where everything about medical and screening checkup comes about. Counseling of deferral donors. Counseling really needs a technical person who can be able to talk to these clients very well with a good rapport. Ensure that they don't feel bad when they are deferred. Talk with a lot of ethics so that this client can come to your side and understand why you have done all this to her or him.
Kindly, you can summarize. I think your time is almost over.
Counseling of deferral clients also, post-donation advice and care. The confidentiality of donors and the traceability of donation should be assured at all times through the use of unique identification numbers linking donors to donate blood and blood components. So the steps that are in the displayed structure below are the ones I've taken you through. At least you can see administration of the questionnaire, pre-donation counseling. If the client understands that I can't continue, I can self-defer. And then we have the donor health and the risk assessment. Now the technical person assesses the risk of the donor. And then the technical person decides that the client meets the criteria for donation, then can go down, register the donor, perform a phlebotomy, do a post-donation care after phlebotomy, screen the blood, give results, and then advise the donor to come back again to start the process. That is after 3 months for male, after 4 months for female. When the technical person decides that the donor doesn't meet the criteria for donation, the technical person, that is not the staff working at the donor clinic, defers the clients. After you have treated this client as a deferral, you also have to decide whether this deferral is either permanent or the deferral is temporal. If it is temporal, then you recall after the specific amount of time. Then if it is permanent, you explain and put a linkage to where the client can continue being helped. So we also have donor interview and the pre-donation counseling. Pre-donation counseling is an integral part of the donor interview. It enables donor selection experts to do. Check that the donor has understood all questions and has responded accurately to the questionnaire, answer the donor's questions and provide reassurance, explain reasons for any deferral, and give advice on seeking medical care if needed. Ensure that the donor is able to give information or consents. So we have already talked about this donor health and the risk assessment. The question aimed at eliciting and risk of TTI should be explained and donor given an opportunity to self-defer. I have already talked. This assessment is particularly important in exclusion of donors whose infection may not be detected by routine screening tests, and signs of disability, malnutrition, pallor, jaundice, cyanosis, dyspnea, or alcohol intoxication should also be noted during the screening. Physical examination, vital signs, weighing are part of the basic health checkup and should be carried out at this stage. About phlebotomy, I've talked step 1. I've talked about step 2. I've done. Ensure good collection is correct. Label the blood collection bags. Ensure that all satellite bags, that's ours, ATASA region samples tube and donor records of the correct donor numbers. Step 3 is skin preparation and venipuncture. Once the vein has been selected, if the site selected is visibly dirty, wash with soap and water. This one I've said. Then disinfect the skin with alcohol swab 70%. This reduces the bacteria on the surface, thus minimizing potential fatal condition of septicemia, which can occur when bacteria enters into the bloodstream, also to the recipient. Apply a tourniquet at the upper junction of the arm. Wrap the skin inward out, moving constrict circles starting at the center. Do not break contact with the skin or overlap the circles. Repeat if need to allow the air to dry. Select large firm vein at the intercubital fossa, priority median cubital, cephalic, and basilic. Area must be free from skin lesions or scars. This one I had already talked. Step 4, anchor the vein by holding the donor's arm. Puncture the vein swiftly at 30 degrees angle or less. Release the donor before withdrawing the needle gently. Arm should remain extended and in a comfortable position. Closely monitor the donor. Observe for any sweating, business, or complaints of feeling faint. Monitor injection site for any development of hematoma, that's the swelling. Once blood is full to the recommended weight, cut off the needle using a sterile pair of scissors. Collect blood sample for lab testing. And this is the sites we were talking about. That is the basilic vein, but we prefer the median cubital vein. With the also second, if you don't get a median cubital vein, we also advise to go for the cephalic vein. And then if it's not there, lastly, we can now go for the basilic vein. It normally doesn't bring out the blood properly, but when all these ones are failed, the other ones are failed, we can go to the basilic vein. We have talked about the donor deferral. Donors who do not meet the selection criteria should be deferred on a temporary or permanent basis. All deferral donors should be treated with respect and care in a confidential manner and should be given a reason for deferral and an opportunity to ask questions. It is responsibility of the healthcare worker to ensure that donors who are deferred due to medical conditions are referred to further management. That is, we can attach them according to their diseases that were found in the screening samples, that is the blood. Temporal deferral donors should be advised on when they could donate and encouraged to return. The temporal donors are like those ones who were operated, those who received the blood transfusion. They are the temporal donors. After they have reached their time, they can always be asked to come back and donate blood. And that is the end. Thank you, my friends, for listening.
Thank you very much for that nice presentation. I think members just keep on posting your questions there. And I think we'll give you a chance to ask questions after this short presentation. I'll want to give to Chris Kwamboka 10 minutes, I think, to do an addition to that presentation. Over to you, Chris Kwamboka.
Thank you, Mr. Chepkok, and thank you, Margaret, for the good presentation that you have taken our attendees through. Mine is just to brush over on what Margaret has gone through, to add on the takeaways, because it has been a long presentation. On donor recruitment and selection, mainly what we consider 3 areas: the safety of the donor, the environment where the donor is going to donate blood, and the space. So anytime a recruiter goes out to do recruitment of a donor session, we have to consider the environment. It has to be a clean environment, spacious environment, free of dust and wind, because normally donor services, we go out with tents or we get rooms on where we are going to collect blood. The rooms should be airy and free from anything that can cause injury to the donor, the staff, and the contamination of blood that may lead into patient contamination. On blood collection, the choosing of venipuncture site, this also we have to consider the donor. It has to be as friendly as possible so that the donor does not experience pain that may lead into donors disappearing, not coming back to donate. Because our aim is to build a pool of repeat donors who are safe. So the venipuncture site, as Margaret has said, has to be chosen correctly. Before you choose to go into a donor's vein, you have to compare both hands. You choose the best vein that you will not need to repeat a puncture. And also we have to consider the safety of our donation. Normally, we don't exercise open system. So once you have gone into a donor's vein, you are not supposed to use the same needle to puncture another vein. That's why before you choose to puncture a donor, you have to make sure you are very sure that vein is going to collect a full pint. And our full pint is normally 450 ml. It can go slightly lower with the -50 or +50. That one will get more details when we move into quality, I think next week. When we move to proper aseptic cannulation technique, that is together with the venipuncture site, the cleaning of the site, it has to be thoroughly cleaned. You have to assess the degree of dirtiness of the venipuncture site. If it needs to be cleaned with water before using alcohol swabs, you have to do it. And this brings me back to when you are preparing to go for a session, we have a checklist that you ensure that you carry everything, all the tools that you are supposed to use at the blood collection site. On donor care and pre and post donor counseling, here we consider the donor results. Normally you have donors coming in to donate, different types of donors. There are those who just walk in voluntary to come and donate blood as goodwill to save lives. There are those who have gone out and done a VCT, tested themselves. And since they have heard outside there that blood donor services or testing labs for blood have high screening machines, they come in to confirm their testing results. So we have to go through the questionnaire, talk to the donor properly, and find out why the donor has presented him or herself to come and donate blood. Overall, the equipments that we go out to use, we encourage proper care of the equipments. So when somebody goes out to recruit, you have to ensure that the environment you are going to, our equipments are safe, our staffs are safe, free from any damage that can come and cause danger to the equipments and to the staff and the donors. On handling the donor services, we recommend that if you are setting up a blood collecting center, you have to have qualified staffs on board, right from recruitment up to the patient in the ward that receives blood. We should have a line of qualified, trained staffs who are able to carry out all the services as required. It is not right to have, especially on the point of donor selection, to have people who are not trained. And the people are supposed to be there, nurses or lab techs who have undergone the donor selection criteria, as Margaret showed us in one of our slides. So I think that is the take homes that I was to add. And back to our moderator. Thank you.
Thank you, Grace. That was that you have really given us the answers. And I think since we are having so many questions here, I want to invite one of our panelists, Mr. Peter Mbugua, the lecturer at KMTC, probably to make a 2 minutes summary on the talk. Peter Mbugua.
Chepkok. Thank you, Margaret. Thank you, Grace, for your comments on this presentation on donor recruitment, selection, and donor care. It was a wonderful presentation with a lot of information. And I would say Margaret covered almost everything, and Grace has done a very good recap, has given a good summary. But the only thing I may add on donor recruitment is that the raw material is as good as the product. Therefore, on this particular area, I would really recommend, we advise our working first-time donors, we look at ways of converting them into voluntary non-remunerated blood donors, because those are the low risk blood donors. Then on donor care, I would really look at it just the way Margaret has summarized it, but then I would put 2-3 words as a take-home messages that on donor care, there is the before the donor is allowed to donate, there is the care that must be taken. And this is the first impression. This is the blood donor first impression. And the first impression is the one that's sinking the donor. It is the one that we encourage the blood donors to be regular blood donors. So when the first thing was about the environment, which is key in this. Also giving adequate explanation on the procedures involved in blood donation. And again, the blood donors should not be delayed. There should be no delay during the blood donation process. And also there should be privacy in pre-donation counseling and all other discussions that are there between the recruiter and the blood donor should be done in privacy. I think it was a wonderful presentation, and we are open for more questions. Otherwise, thank you very much, and thank you for inviting me in this particular presentation as a panelist. Thank you very much, Mr. Chepkok, Mr. Moderator. Thank you.
Thank you. Thank you, Mwalimu Mbugua. I'll want to invite also Alfred Obengo, who happens to be a board member at Kenya Tissue and Transplant. Probably you can talk about some of the administrative or the support when it comes to donor Haemovigilance. Over to you, Alfred Obengo. Obengo, you can get us? Yes. It was given. Obengo, can you get us? As we wait for Bengo, I don't know if Dr. Lotodo, you are with us? Dr. Lotodo, you can give your comments before we continue with the questions which are here. We have a couple of questions which has been raised by the participants today. So as we wait for them to join in, we have some questions, and one of them, I think this one will go to Mbogwa. Mbogwa, there is a question which is coming here, and they're asking, after COVID infection, how long should one take before somebody donates, that is after recovery? The second question will also, I'll want to take it to Mr. Mbogwa, is the ceiling of the 65 years. What is the rationale, and should somebody donate after 65 years if he has been a regular donor? This one will go to Kwampoka. There is a question which has gone to physiological difference between 15 years and 16 years. Why are we basing ourselves to 16 to 65 years? Why not 15 years? I think we can take that one. And also still to Kwampoka, somebody with, when you talk about body weight, is it a factor when it comes to donation? And you can marry with this one of overweight. Should somebody with overweight donate blood? Let's start with Mr. Mbogwa. Mbogwa, you can come in with the questions I've given.
Can you hear me now?
Yes, we can hear you right now.
Okay. I'm saying that the literature that was there is that after somebody has recovered from COVID-19, he should be eligible for blood donation after a month. That's 30 days, should be able to donate blood. But maybe with more information and more research be done on this, could be there will be some adjustment. But that is, the literature was saying after a month or so, one is eligible for blood donation. The other question was on why we don't collect blood from people who are at 65 onward. After 60, I would say even after 50, there are so many changes that are taking place in our bodies, and those are the individuals who are becoming hypertensive, diabetic, and many other conditions. So we should allow those people rest at 65 and concentrate on that age bracket of 16 to 65 years. And that's my observation. And well, that is my observation, and that's the way it is. And thank you.
Thank you, Mbogwa. Kwamboka, come with your questions. I think I had given you 2 questions. That's about overweight and physiological difference between 15 and 16 years.
On overweight, actually, that is the overweight of an individual, that is a weight above. We don't have an upper weight limit. So long as the donor's veins can be found. If donor's vein is not, because of many fats in the body, is not able to be traced, that's now when we can say that we cannot take the donor. But so long as the donor is healthy and able to do his physical exercises well, able to walk, we don't deny that donor from donating blood. The other question, Chepkok, the other question is?
Yeah, the physiological difference between 15 years and 16 years.
The difference between a donor who is 15 years and 16 years is mainly the physiological changes that take place in the body. This is the period when the bone marrow is maturing. If you are below 16 years, your bone marrow is not yet fully matured to produce mature red cells. But still, I can push the question to our panelists to build on it. But that is the basic reason why we don't accept donors who are below 16 years, because they are at their age of turning from childhood to adolescence. And that is when so many physiological changes are taking place in the body. Thank you. Back to you.
Thank you, Kwamboka. Probably again, I'll, if you want to ask a question, let me see your hand. If you put your hand here, we can be able to give you the time to ask a question, but I'm still using the chat box. There is a question here, and this one, I want it to go to, okay. Okay, I'm informed that they can only type your question. There is a question here on donor questionnaires. Is it standard or something which can be customized to an individual blood satellite? Then the other thing, why do we say that? Again, this one can be taken by Mbogwa. Why do we say that men should donate after every? He has written 5 months, but I think it is 3 months, and women after every 4 months. Donor questionnaires, I think Kwamboka will have to come to that. Then I am getting another question here. Do we use any local anesthesia before we do the breaking of the skin? Again, Kwamboka can do this. Over to you. We can start with Mbogwa.
Thank you very much, Mr. Chepkok, for that question on exactly why males are allowed to donate after 3 months and ladies are given 4 months. Actually, the reason is also as to why men have higher HB levels than ladies. Why do we recommend higher HB levels as norms for men and low HB levels? Because men have HB levels starting from 14 and ladies have 12. The reason is the way God created us, the hormones, the way we were created is to why we have more muscular, we are more energetic, than females. That's the reason men should donate more times in a year than females. But I also encourage my panelists to come in and put more muscles in that. But that is the reason as to why men are allowed to donate more times than females.
Kwamboka, kindly come in with your answers. Kwamboka, you can listen to, you can hear me. Are you able to, are you catching me, people? Because I'm trying to get Kwamboka to answer that question.
We are getting you. We are getting you.
I think, Mainini, can we give this? Yeah, there is this question here. Great presentation. When it comes to diagnosis such as HIV, whose incubation period is 3 months, what happens when blood is donated and retested? Does it get retested again after 3 months before use? Administrator, kindly give Dr. Makori to answer this question. Dr. Makori, if you can unmute yourself, if it's able.
Thank you, Chepkok. To the person who asked this question, I would like to remind you that this is one of the reasons why we are encouraging for donors to be repeat donors, because we prefer to work with people who have worked before, people who were tested, and we can trace the testing. And on top of that, the tests we are using for diagnosis of HIV are selected with having the highest specificity and sensitivity. So we minimize any infected person who can pass through the testing. And having the highest specificity and sensitivity means that even the smallest amount of antibodies will be detected, and also it is not likely to detect antibodies from other viruses that may be similar to the HIV virus. The other question, the suggestion you gave, whoever asked this, to retest blood after 3 months, that will be futile, because remember, the antibodies are being formed in the body, not in the blood. So once you have withdrawn the blood and you have it, even if you retest it after 3 months, nothing really has changed, because remember, the immune system is within the donor, not really in the blood sample you have taken, because the few lymphocytes there may not be enough to mount an adequate immune system to start now producing antibodies. Thank you. I hope I've answered that question.
Dr. Makori, and I think you have put it very well, that what we are using is both high sensitivity and highly sensitive and specific. And the other thing is that we also tested for antigens. The antigens are the real viruses, which is always present in the blood. I'll take this question to one of our presenters. Was it Maggie? On tattoos. There is this question: people with tattoos, can they really donate? If yes, or if no, why?
Previously, with our questionnaire, we had said that people with tattoos, some might be deferred, others may not be deferred. The reason is, normally these people who make tattoos, they share the instrument that they use in making their tattoos. During the sharing, they might be transmitting diseases from one another. And that is the reason as to why we normally refuse those people with the tattoos. We also have another reason why we refuse those people with the tattoos. Sometimes when they are doing those tattoos, they are putting some drugs in those cards. So these drugs might be having some effect to the blood in one way or the other. So that's why we normally refuse them not to donate, and they can donate after a specific given time. I think that is it.
Thank you. We still also have another question. We have, I don't know, this one should be Kwamboka, or if Obengo is in, do we have local anesthesia available for use by donors to reduce the pain of needles during phlebotomy?
No, we don't have local anesthesia. Hello?
Yes, continue.
We normally don't have any local anesthesia when we are doing a phlebotomy, because the way we do this phlebotomy, it doesn't have any very big pain that can require anesthesia. Normally the pain is shallow, because I know what is normally given anesthesia is the pain that can even cause a neurogenic shock. So we don't have anesthesia, local anesthesia for that.
Then there is this other question. This one can go to Mr. Mbogwa. Can I donate 2 pints?
No.
Can I donate 2 pints?
Hello, come again.
Can I donate 2 pints?
Thank you, Mr. Chairman, for that question. Actually, you cannot donate more than 450 mL of blood. The maximum you can donate is 1 pint of blood, not 2 pints of blood at a go.
Again, let's go to the other one. I think we have talked about a questionnaire. Kwamboka, can you tell us about the questionnaire? You didn't answer this. Is it universal or something which can be customized?
Well, the questionnaire is customized to our country, but mostly the questions that are asked, we have some that are universal, and there are those in the questionnaire that are specific to our country, Kenya. Thank you.
So in real sense is that we have standardized the answer for the country, and it is used universally all over the country.
Yeah.
I don't know if Dr. Makori is still around, or Dr. Kibet. The question is, there's a patient who is ABO blood group, that is AB positive, but when her serum is cross-matched with AB positive donor cells, she reacts. Same case to blood group A positive and B positive donor cells, shows a reaction. What might be the reason for her to react with all bloods that should be compatible? If Dr. Makori is here, or Dr. Kibet.
Okay, please, can you repeat the scenario? AB positive?
This is AB positive, but when the serum is cross-matched with AB positive donor cells, she reacts.
Okay.
The same case with AB positive and B positive donor cells, shows the reaction.
Okay. You know, the AB rhesus grouping is not the only blood group system that exists. There are so many others. Actually, there are like over 200 systems. But the one we do here is AB and rhesus. grouping. That is why once you have determined your AB grouping and rhesus grouping, we have to do a cross match. We know that you can have antibodies. You may still not be compatible with a person of the same AB rhesus group as you, because there are some antibodies you may have that to which they have antigen. And that is why now the serum would be reacting. So when we are faced with that, we'll now expand the area we are looking for donors. And we also nowadays, like in Kenyatta, you can do antibody screening. We screen and see what type of antibodies are there. So how would this person develop those antibodies? There could be innate antibodies, the ones we are born with, or the person could have been exposed to some other elements. Maybe somebody has received a blood transfusion in the past and they got sensitized. Maybe it is somebody who got an organ transplant like that. But also, we know that is the reason why women, especially those who have had many children, more than 4 children, are not good blood donors because they tend to be immunized for each pregnancy they go through. So there is a lot to blood transfusion. It is not just the AB and rhesus grouping. There are so many other minor blood groups, and we can still carry antibodies to them differently. I hope that I've answered that question.
According to me, it's well answered. Mr. Mbogwa, there's a question for you. Is it possible for rhesus to change? Have I encountered mothers in the labor ward where during their first pregnancy, they were rhesus positive. In the second pregnancy, they are rhesus negative. Kindly comment.
Thank you very much, Mr. Chairman, for that question. The inheritance of the blood groups are controlled by the Mendelian law of inheritance, whereby each parent contribute equally to their offspring. Blood groups are inherited. Blood groups are not acquired. So when somebody is rhesus positive, or when somebody is rhesus negative, it indicates that that person lacks the antigen, meaning that this particular person never inherited the gene. And if the D gene was not inherited, then we don't understand how in between the process you can find it appearing in the system and somebody converting into rhesus positive. So to answer the question on this, Mr. Chairman, is that could be some misgrouping, the initial subgrouping, or maybe the grouping was poorly done, either the first one or the subsequent one, but blood groups do not change. Thank you, Mr. Chairman.
Thank you, and thank you for for that answer. I don't know. There is one question here from Ngayo Zairu. Over time, I noticed blood group A positive given to A positive patients easily reacts. Is there some sense about this compatibility that hasn't been discovered? I don't know. This one I can say, I don't know if we have statistics, but let me take it to Dr. Makori. You can comment on this.
Sorry, I received another call. Can you please repeat the question?
There is this from Gayu Dairu. Over time, I noticed blood group A positive given to A positive patients easily reacts. Is there some science about this compatibility that hasn't been discovered?
I think it goes back to those minor blood groups. If you see the way the blood group is formed, those antigens are formed in our body, the initial one is A, then it changes, then it becomes B. So that is why we say the highly immunogenic blood group is blood group A. So patients may still react to the same blood group, and that is the reason we do cross-matching. Because the fact that you are blood group A doesn't mean that the only antibodies you have is anti-B. You could still have other antibodies to other minor blood groups. So that this goes back now to what I had said before.
So thank you, Dr. Thank you, Dr. Magori, for that. There is this other question, and I want probably again, Mbogwa, you can handle this. It is on why do somebody with high HB that is above 18 not allowed to donate? And number two, can albinos donate?
Okay, thank you, Mr. Chairman, for your questions. First and foremost is that one of the key principles of who a blood donor is, a blood donor is that individual who is a healthy blood donor. So when one's HB is above 18 grams, 20 grams per deciliter, this particular person is not healthy. And any donation made from somebody whose HB is above the normals, is above the normal reference ranges, that blood should not be given to the patient because it's from a source or from an individual who is not healthy. This is somebody who could be having polycythemia vera. So this blood is cancerous, should not be given to a patient. Thank you, Mr. Chairman. Hopefully I've answered that.
Thank you very much about that. I think this one is this one is coming from Peter Kamau. Whenever a patient needs blood, the relatives are able to mobilize people to donate. When a volunteer blood donor exercise is announced, the same people never wants to come out. What's the government going to do? See, and the landscape change. And I don't know if Obengo is Obengo in? If it's not in, I can take this one, and that is why we are saying that we need volunteer regular blood donors. That's why we are doing a lot of sensitization to ensure that people will always come during their time. Whenever we have this, it means that we shall be having blood in our blood banks, and nobody will be telling the relatives come. According to the WHO,
2046.
kindly mute yourself, Dr. Makori. Whenever, that is why we are saying that we should not always do replacement donation. This is against the WHO guidelines. These are risky donors, and probably I think, Kwamboka, you can still add something on that?
Yes, Mr. Kiprono. And we don't encourage replacement donors because from experience, you find that these donors, when you check the statistics, they are the most donors who are not safe. And as WHO recommends, we should practice voluntary non-remunerated donations. You find that these relative donors, some of them, when we take them through interviews, we realize that they are paid to come and donate. This is because the relatives are desperate, but we try to convert these relative donors into regular repeat donors once we give them their results, and we encourage them to come back after counseling them, informing them of the need, why we have to look for relatives, because our banks are not sufficient. And so far, we are trying as KTTA to encourage coming up of satellites and blood collecting centers so that we take services to the nearest to the donors and advocating for voluntary donations. Thank you.
Thank you very much. I can see time is coming to the end. And before we do this one again, is that we have an application known as DAMU-KE. You can go through the health portal and you'll always see DAMU-KE. This is where we can always encourage everybody to register as a blood donor. And this one again will always, after donation, will always tell you the time when you can come back. We have questions concerning CBDs, people that have not been receiving CBDs from last year to this year. I don't know, Kinuthia, Dr. Kinuthia, can you comment on this for the people who are here? We have those questions. Or anybody from KNH? Kindly, somebody from the KNH on the CPD points, comment before we do a close.
Yeah, good afternoon, everyone.
Oh, okay, okay. When do you?
Okay, for the few ones who have raised their concerns on CPD, we've requested them to do specific follow-ups and submit their emails to KNH-CPD@gmail.com so that we will follow specific ones who have not received. But for the others, we will be sending through the email. The others who have asked about their details, during the time that you register for the webinars, there are those details that you asked, like your designation, institution. We capture them, they are auto-captured on the register, and when you attend the webinar, it auto-updates your attendance. So those are the registers that we use to issue CPD points.
Thank you very much. I'll want to give to my panelists to give their closing remarks. I'll start from Kwamboka. You can give your closing remarks. 1 minute each.
Mine is to encourage each one of us. I can see we are a big cloud that has attended. If each one of us could make a point of donating blood, this story of insufficient blood in the blood banks could be over. And tomorrow, I encourage all of us to attend our continuation webinar series for donor-related advanced reactions and blood donor notification and leakage to care. Thank you.
Thank you. Margaret Moige, your closing remarks.
I want to thank the panelists, the moderator, and everyone who has attended. I want to say foremost that there are so many questions I can see here. Given that if we had enough time, we could really appreciate to answer all, but because of time, we are not able to answer every questions. We are looking forward for tomorrow so that we can continue, and if there will be, because tomorrow's slides are not so much, if we'll get time tomorrow, we'll be able to answer some other questions. Thank you, and God bless you.
Thank you. Mr. Mbogwa.
Thank you, Mr. Chairman, for this opportunity and also an opportunity to meet so many participants and on blood safety and on blood recruitment and blood selection. It's only that to inform you that here at Kenya Medical Training College, we have a 30 hours course on blood donor recruitment. Maybe this is an area that has never been explored, but we came up with a curriculum on blood donor recruitment. It's detailed. It has got 9 modules, and it will take 1 week. And the kind of discussions that we have gone through, I can see that this course can really be useful to all of us who are recruiters, and especially more so to the recruiters and all of us dealing with the blood transfusion. Thank you, Mr. Chairman, once again. Thank you.
Thank you. And lastly, Dr. Makori joined us. You can make a comment.
Thank you, Chair. And I wish to thank all those who attended and to welcome them. Whenever you have a question about blood transfusion, please, could you be asking even those who work in the blood transfusion unit? They are so eager to answer your questions, because I'm sure you will get so many questions from your patients, and some of them are difficult to you. But if you are guided properly, it will be easy always to answer and reassure patients. Otherwise, I wish to reassure you that all the blood and blood products given locally are safe, and there is no fear that we may be transmitting infections. Thank you.
Thank you, the whole team. Mine is to thank everybody. I think today we reached more than 1,200 participants, which is good. This session will be continuing tomorrow at the same time, but still on donor hemovigilance. After that one, we can go to the recipient hemovigilance, and it will be continuing next week. Otherwise, have a good evening, and thank you for joining this space. Have a nice day.
Thank you.
Karibuni wote.
Thank you. Goodbye.